Good night, everybody. If you can hear me, let me see some indications.
We can
Good
hear.
evening, good night.
Good evening and good night. All right, so I'm sorry to be late. I was having a little bit of difficulty. Um, oh, where am I here? I was having a little bit of difficulty getting on. It's beginning to rain. The inclemency has started in my neck of the woods. All right, so here I am. Is everybody seeing my slide?
Yes, Dr. Harrison.
Ah, great. All right. So I'm not going to be turning on my video because usually I have bandwidth issues. All right, so tonight we're going to be having a discussion around the application of family health principles in practice. So as per usual, I say these are things that you already know that we are going to be discussing. But we appreciate that family forms the basic societal units, and they're founded or they're foundational producers of individual and community health. So we can appreciate that. We also support the idea that health begins in the home and that health is influenced by the family. And this notion is not only supported by theoretical models, but also scientific evidence based on family-focused intervention at the primary, secondary, and tertiary prevention levels. Therefore, delivery of this family health component recognizes the family as an essential context for the development of health, which includes all family members across time and setting. Also, we agree that family health promotion has a responsibility to focus efforts on including families within strategic partnership, public health programming, and so on. So tonight, we'll be discussing some ways we can use or apply family health principles that we've learned theoretically in practical ways. This is kind of, how should I put it now, kind of paradoxical, because I'm talking about using theoretical knowledge in practical ways, but basically this is theory. Hopefully though, when you do health promotion and you'll get a chance to apply these theories in or the theoretical knowledge in practice. So here's our session outline. We're going to be looking at public health versus family health, some assumptions of family health. We're also going to be looking at family health through the lens of the system levels approach. If you notice, I'm always using that system level ecological approach. Why? Because I find that it's overarching. It's applicable almost to everything that we do, as long as we're working with people. We're also going to segue into some principles of family health, and then lastly, looking at applying these principles of family health. So public health versus family health. Public health, the definitions are there. What we do together as a society to ensure conditions in which people live. And of course, family health is used to represent anything from maternal to child health to reproductive health. So public health, I believe, subsumes family health in that it attempts at ensuring healthy conditions for all, including activities spanning maternal, child, reproductive health as areas of focus for family health practitioners. Whereas family health, on the other hand, is a comprehensive approach, I feel, that considers the health of family as interconnected unit. Interconnected unit in that each member of that family, if you consider each member of the family to be a system, these systems are interconnected to form the family as a whole. As a matter of fact, when you look at the ecological model, when you use that ecological system model, it considered an individual to be a microsystem. Because I might have said this to you before, When we talk about system, we are talking about interrelated parts coming together to form one whole. And so if an individual in and of himself or herself is a microsystem, we see where many microsystems, many individuals come together to form that family. Hence, you'll find that this systems model will look at, families as interconnected units. So the importance of family health. I think I know I have some narratives here, but I want to hear from you, class, because I like my class to be interactive. What's the importance of family health? Why is family health important? Talk to me.
Well, it's important for a lot of reasons.
Go ahead, Akib.
I mean, at the very core of it, family health really, families in general, family health, families are shaped by a lot of conditions, and the influence of health on the family in the very definition of health, as is stated, goes beyond, physiological, mental. There's a lot of social aspects. There are a lot of things that contribute to the health of the family. So, a healthy family environment and a healthy family structure will translate to a lot of good things at many levels, from nutrition, hygiene, vaccination, emotional support. Oh, well, right. That all of those things. Right.
Yes. So keep going, Akib, keep going.
I lost my train of thought a second there, but yeah, it really affects how your family then behave after that, how the health behaviors that come out of that, and performance of kids, the performance from a economic perspective of the working class people, the health of the elderly, you got many issues that emerge at the family level, all of those things that you have there, Doc.
Exactly. So I'm helping you right there, yes? So,
Yes.
so basically, you're agreeing then, or we're agreeing, Akeem, that aside from disease cure, family health offers a variety of activities and programs for disease prevention, rehabilitation, and health promotion for all family members. And this
Right.
translates into, you say a healthy family. So I guess you were looking at, the health of each individual, make a wholesome, healthy family. But if we were to look using again the system approach or the ecological approach, when we look at families, whole families make up communities. And so if the families are healthy, our communities will be healthy, our nation will be healthy, right? So it's more than just the sum of those members, individual members. It considers also, as the second bulleted point says, it considers their interaction with one another, as well as the family's, biological and physical environments. It uses markers, and you mentioned some of these, demographics, genetics, physical, mental health, social health, the socioeconomic status of individuals, and the culture within which people operate. Yeah. And so when family health practitioners, public health practitioners, all of these things are variables that you consider when you're doing your assessment, when you have to do your intervention. Therefore, we also know that many of the health issues emerge and are treated at the family level. So a lot of times an individual comes to you, and of course, as practitioners, whether you are in your specific fields, medical field, teaching or educational field, I want to say public health, because sometimes we do have public health practitioners here too. So whatever it is, whatever your field is, when you deal with an individual, when you treat, but not say treat, let me say intervene. When there's an intervention, Although you might be dealing with one person, that person cannot be divorced from the family because this person has those genetic markers. Yes? That person has to go back within that household, and it could be the environment within which this person lives that is really spawning whatever the presenting complaint could have been. It could be the culture within the community. Well, the family has a subculture. Even though there's a larger culture, usually the family, there is a subculture, and the subculture, as I said before, whether or not these persons are financially independent or whatever is going on, of course, can spawn some of the very issues with which your client or your patients present. So family health is very important. In summary, I would want to say that the family influences lifestyle, behavior, access to care, and they form the cornerstone of community health systems. So it serves to bridge the gap between individual and community health. Now, some assumptions here of family health. The family is seen as a nucleus around which focus is centered. But is this always true? Hello, people.
It's not always true because sometimes
No, miss.
it's individual.
But as a medical doctor, Akeem, when that individual comes to you and you're collecting your fact sheet data, what questions do you ask?
Well, among the many questions, you do ask for the next of kin when you're registering the person that comes up. If it's a child, you're gonna need the parental information, or whoever is in guardianship of that child is gonna come up, of course. And at the level of their presenting issues, depending on what you surmise, you might want to look deeper into their family history, their
You
exposure.
always, that's the buzz term I'm listening out for. Always. That is like a staple when you're doing that eliciting the socio-demographics, eh? That's like a staple for you to ask about family history of the presenting complaint, eh?
Right.
So even though you're working with that individual, you see how this comes around now, Akim. Even though you're working with that one person, the family here is important. You want to find out, what is your family history where this is concerned. And for persons who would have been, I go back to a pardon me, whoever is here that I'd never taught in undergrad. I think it's year 3, we do a genogram where we look at the family history in the context of health for 3 generations. And there's a reason we do that, because things run in the bloodline. And so we want to find out, and it doesn't have to be only medical, it's not just genetics, psychosocially. Within families, there might be mental illness or substance use disorder, which runs in that family. And the substance doesn't have to be like crack cocaine. It could be nicotine use, it could be marijuana, it could be alcoholism. Yeah? But that's a substance use disorder going on in the family. And sometimes if we were to do our own genogram, we would recognize that there are certain things that run in the family. It could be early pregnancies. Yeah. Early pregnancies, suicide, stuff like that. You realize, somebody attempted, somebody committed, stuff like that. Yeah. It could be even the profession that you gravitate to runs in families. People of the army, people in the force, stuff like that. All right. So the family is seen as a nucleus around which focus is really centered. Sometimes the focus isn't there because, the attention is not on the family in totality, but just one member. And the second point is saying now, the family system perspective recognizes the multidimensional aspect of care. So the family-centered approach to practice appreciates the role of family based on the assumption that the best way to help any individual is to view that person within the context of family, neighborhood, and community at large. That is why, as public health practitioners, you look at the larger picture. Yes? So you're looking more at the macro scene, the community and the society at large, even though you might be working with individuals, for the most part, but your focus is wider than just that individual coming to you. All right. So the family centers, exactly. So the family-centered approach assumes that the best way to help any individual is to view this person within the context of family. All right. So we're looking at family health now using that systems level approach. You hear me keep talking about systems, and remember what I say. So we know that system has two definitions. One, a way of doing things. In this context, we are talking about, and I repeat the definition, interrelated parts coming together to form one whole. And I would have said to you, there are three basic systems. I think the last class we had, I mentioned this, three basic systems. The microsystem, and this microsystem, I'm saying one person, an individual is a microsystem. And then when you go farther afield to look at the community, this second layer could be seen as a mesosystem or the community system. And then you go farther afield to look at the macro level system, which now we are looking at things at the societal level. So family health using this system approach now at this service level, the family is like a recurring decimal, I want to call it, in any individual social environment and should be targeted for consultation and support. So, a lot of times persons come to you, you need that co-historian, not only when persons might have, a mental health challenge and you have to get the view of a significant other. I did mention substance use disorder. A lot of times when you work with people who have, substance use disorder, they are addicted to something. They minimize use. And so that co-historian is important. And usually that co-historian is the family who will give you another spin, another take on that presented problem. Now, so moving from, so we're looking at the service level, the family seen as this, it says constant factor here, I call it a recurring decimal. And this family is situated within the community. Now, sometimes we don't appreciate, or we appreciate, but we just take for granted how important individuals are within their community. And I say to people sometimes, imagine one person in this community who is the only dressmaker. Yes. So yes, of course, we know we hardly go to the dressmaker to make our clothes anymore. But a lot of times we buy stuff that we need to be altered. We can't do it ourselves. Well, at least I cannot do it myself. So I need that dressmaker. I need to take it to somebody who I know can do this alteration. So imagine this one person who we all rely on, and this person gets ill or this person dies. The skill set here is almost lost to the community. This person was very important and we just took them for granted. I remember saying to some students too, growing up in a rural area, Jamaica, in St. Elizabeth, growing up, there was one shoemaker in our community who everybody went to heal their shoes, to sew on, bottom, to do all kinds of things. And when that man died, it was a real loss within our community. So we see where, even at the individual level, how interconnected each family and each individual is within the community. And when we now look at things at the macro level, at the policy level, family-centered and family-friendly system actively support family involvement in decisions. So what are we saying here? We're saying at the policy level, family-centered and family-friendly system, way of doing things now actively support how involved families are in decision-making, including financial policies, procedures, structure, organization of programs and agency. Do we do this in real life? I don't think so. Sometimes I know, our governments or policymakers or, I don't know, senators, whoever you call them, might have town hall meetings and you hear they send out green paper and white paper. How many persons, how many ordinary family member even take the time out to peruse these papers and to, attend town hall meetings and stuff like that? Not many. It's almost as if in Jamaica here we don't have a culture of engagement like that at the policy level.
But I add that many
Yes,
times
Akeem.
you don't even know about it because it wasn't until recently that I happened to see the Ministry of Justice released a call for public input and consultation on in one front on the I think it was dispute resolution, and before that it was the AI task force.
Right.
And previous to that would have been the 2019 Green Paper on the National Health Insurance Plan, inviting recommendations and opinions and so on. But
From ordinary people,
the
yes.
average person doesn't even know that these things even exist. It wasn't until I became an MPH student I even knew that these things existed. So
They
the
do.
institutions themselves need to be more mindful and need to make a stronger effort in actually making the population aware that these things actually put it on the news, put it on the
And
radio.
explain to them, Akeem, the importance of this and what it means and why we should be
Right.
involved.
Absolutely.
Because sometimes you hear these terms and it just goes over your head. Yes. Luckily for me, back in the day, back in the 80s, I worked at the Ministry of Finance and I knew about, green papers and stuff like that, submissions and so on and so forth. So I knew these things and I know that the public ought to be a part of this. And so now and again, as you say, you hear it mentioned, but the ordinary man doesn't understand any of this. Yes. So as you say, it needs to be explained, but you remember the last time we met, I talked about, the positive functions of being poor. Well, I too believe there are positive functions of people lacking knowledge, of people being ignorant. Because when you're ignorant, you make certain decisions or you allow people to make decisions on your behalf and you're not quite sure, what decisions are being made on our behalf. All right. So you are positioned here. You are being trained to go out there and you are already leaders, all of you leaders in your own right, but now you are acquiring certain skill set. Johnson, Hamilton, were you talking to me a while ago?
No, miss. Sorry.
Oh, all right.
I'm
Yeah.
listening.
So I'm saying you are acquiring, certain skill set that will make you even, what should I say now, broaden your knowledge base, raise your consciousness to another level where when you go out there, you now speak with authority when you go in communities and you engage at the policy level. All right. So family health using the system levels approach. We say, I repeat, at the service level, well, it's there on the slide and you're reading it. The family is seen as a constant factor in the person's environment and should be focused for consultation. Yes. At the individual level, of course, that should be done where the person should be partners, where decisions are to be made, where this person is concerned. And of course, when you're entering people's community, you must engage community members. And in engaging community members, of course, inevitably you're engaging families within that community and at the policy level should be family friendly, yes, and family centered because families make up whole communities. Yeah. Moving right along. So in family health, attention is to be paid to how information is relayed to family members and information is elicited. Again, this sounds redundant because we just said it earlier that families should be involved in choices and the services which are offered, whether in a convenient time or place, which is attractive to individuals. Now, this third bulleted point here. I think it services being offered, in a convenient time or place suitable to or attractive to individuals is dependent, I feel, on resources available. Yes, but nevertheless, in family health practice, being sensitive to the capabilities and or the cognitive prowess of individuals or family members targeted for intervention is very important. And that is why you have to pay attention to how you share information and how you draw information from people that you are interfacing with. Therefore, garnering and relaying information in ways that match the ability, and I would want to say match the conceptual levels of the recipient, of those individuals to whom you are relaying the information. Eliciting input from family members from the outset of the engagement and tailoring services as best as possible to meet individual family needs. Now, I hear, I think it's implemented already, and I think it was implemented on a phased basis. I'm talking about the work, what they call it now? Help me here. Where you have the staggered work week. What's the proper name for it?
Flexi work weeks.
Flexi work. What do you think about flexi work in terms of, so we are looking at this in the context of family health now. Services being offered in a convenient time. What do you think about flexi?
Its basis is to have a proper work-life balance. That's the basis in which it operates. But locally, there's some caveats with it that
Yeah.
would make it it would make it kind of counterproductive because in the staff orders released today, they're saying that all of the staff in core staffing should be in office between 10 to 3:30, which makes absolutely no sense because if I want to work at 6 to 2, that's 8 hours.
Right.
So, but at its premise, at its core baseline, it's amazing. The implementation, questionable.
Right. So I didn't know that there was, I'm behind time with it. I know it's implemented in, it's rolled out already, but the caveat in terms of everybody should be in office between 10 and 3.
Yes, those are core
Mhm.
working hours
4.
according to GOG.
Because when you look at the hospital setting, I know that at 3 is when some handing over is taking place. Well, that's kind of different, eh? But I mean, when you look at one of the things I think it would ease, it would be the transportation, the traffic jam on some roads. Yeah. And as you say, persons wear different hats. And so some persons would have preferred a 3 to 9 or something other than being at work, having to be at work, during those core hours, they want to call it. Well, I guess it's early days yet. And so as time go by, modifications can be made, but the gesture, I think, is worthwhile. All right. So recognizing that next of kin might not be family by virtue of marriage or adoption, families of association or surrogate. So what am I talking about here? When we pay attention to family. When you go in the hospitals, it talks about next of kin. But we have to be careful that, they're families of association. And it's not by virtue of somebody being married into the family. So it's not the family of origin. but people consider themselves family. They live like family. They call themselves family. They are important to this person or to the person who is a focus, for the help, for the intervention. And so we have to recognize the importance of these families of association or surrogate families. For example, let me see if I can get a good example. I know families of association would be, for example, like children in a place of safety, in a children's home, and the communal basis on which they operate. They consider themselves family. I also know of a real case of an older woman now who worked with a family. She worked with a family, did babysitting. She took care of all the kids. The kids are now grown, married, and have kids and grandkids. And she's still with that family. And so this is a family of association. She came there to work. She never left. So 40, 50 years on, she's still within that household. Yeah. So we have to recognize that these persons, this family of association, or we can call this now the surrogate family to this older woman, is the next of kin. Yeah. So some of these things, she might go to the hospital and say, who is your next of kin? And she say, is she your sister, your brother? No, they're really her employers, but they live like a family and she's been with them for decades. All right. So changing gears now
Just
to
on
look at,
that point, Doc,
yes.
I've witnessed more than once, like in the public sector, if a person shares that information and said, well, they said, what's the relation? And the person says, oh, my employer or family friend or something, but not biological family. Um, I've I've heard where records say to them, no, we can't use that person. The person
Right.
have to be a blood family. And then the
Mm,
person said, what if I don't have a blood family that's alive or that I'm close to? Because remember,
mhm.
you're putting this person on my record. Suppose I don't want this person to be privy to my
Right.
medical information, and they opt to leave it blank. So I'm trying to figure out what I mean. Yes, I know it's policy, I guess, but and that's how they were trained. But how
But for
do
me, it's an insular view though, Vanessa. For me, it's pretty insular. If the person has his or her all her faculties, let's say the patient, Vanessa, has all his faculties or her faculties and say, listen, um, this is my family. I've chosen them as my family, and they're the ones who I want to be privy to my information. The patients have self-determination. I don't see why. I know records. I know now it's like a value conflict because or an ethical dilemma almost because on one hand, the records people are trained. If it's not blood relative, it's not kin like that, no information can be given, so on and so forth, or they will not accept that information. But on the other hand, the patient has self-determination and is saying these are the people who I want, or this is the person who I want to take care in the event this happens, to take care of my affairs or to make decisions on my behalf. So that's understood, but I think it's an insular view. All they need to do for me to absolve themselves of any guilt or any repercussion later on is to make a note to say, patient says so on and so forth, and have somebody sign it and co-sign it or witness it. Yeah. But I think, some education in this regard is needed also because I'm saying, and the literature is out there talking about, there is another term, fictive kin. Very oxymorous, I find that term, fictive kin. And it is the same thing as families of association or these surrogate families, right? And fictive, we know something is fictitious, it's not true, it's almost pseudo. But the kin speaks to blood. So, but they're not blood, they consider themselves family. So you see this case I'm telling you about, Vanessa, I'm telling you all about. It's a real case I work with. This woman worked with the family for over 40 years. She is still there. the family takes care of her now in her old age, but they are not biological. And so if they were to come to me for any assistance, you putting on my social work hat and they come to me for any assistance, they're the family I know and they're the family I work with. Right? So it's understood, but maybe the hospital policies, I don't know. I don't know how, what
I
the
was just
legal
about to
implications
add
are.
that very word, policies, but they
Yeah.
need to be less guided by what they think can be used and more guided by policy and legislation. What does the law say? What does the institutional policy say? Because based on my very little knowledge of the law, I'm no lawyer, but I remember this came up in a conference just a few weeks ago, where one of the law keynote speakers mentioned that in the case of the deceased, there's a certain vertical ascent in terms of who gets contacted, or someone who is very sick and cannot make decisions for themselves, whether due to mental incapacity or
Right.
otherwise other incapacity. There's a certain hierarchy of who gets to make decisions. But in the case of establishing next of kin, the person gets to decide who that person is, whether there's a
Yep.
blood relative or not. From a
Or
legal
not.
perspective,
Right.
they get to say. But it seems as though the records personnel are going on what they think or what they've been told, as opposed to an actual protocol or law itself. So it matters that they get exposed to actual protocols and they
Yes.
practice that and not what
Yep.
they feel.
And not what they think or the old way of doing things, because I feel, Akeem, that is the old way of doing things being passed down.
Right, the tradition, just the tradition.
Yes, 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 yes. And so some education is needed
But
there.
I think some of it may be that because the law states who is
Family, next of kin.
right. So it says mother, it says father, it says grandmother, it says, and it literally
Everybody
lists them in
biological.
order
Right, it
of
does, it
who.
does.
So some of it is really protecting yourself, because if the law is saying these are the persons who are family, and then I go now and allow this lady who is a neighbor to
Right.
make the choice, and then the mother of the person turns up, what do I have legal standing?
Yeah. So all of those things need to be considered. But then again, as I say, because and Akeem agreed that if the person has all his faculties, is able to make that kind of decision, is very lucid and cogent and whatever word we want to use. And the person says, this is who I want to, you know, act on my behalf. I don't see why they shouldn't take this person's word for it. The person might not be able to, power of attorney, yes, I know that's important, but the person might not be able to get the services or afford the services of a lawyer, to do this power of attorney. So I think they should take his word for it, and that is why I say, well, have them sign something, have a JP witness it or something, almost like a will. Have a JP witness it, come back and say, this is it. So in the event you're covered, if somebody turns up and say, hey, this is my long lost dad, I'm the prodigal child, and I want to, assume responsibility now, that, the person is covered. All right. Thank you for your input. So moving right along. Oh, why is this not moving? It's not working with me. All right, let me see what's going on. All right, so now we're looking at the relevance of public health in context, incorporating family health principles. Of course, we know ensures holistic, or it should ensure holistic, sustainable solutions for community. Seeing the family as a primary context for health education, helping them to manage chronic conditions, and empowering families to address family barriers. Mitigating health disparities by addressing family level barriers, as I said before. So, of course, public health in the whole context of family health as public health practitioners, part of your remit is to do some of these things. Yes. Working with families, the health education is very important. And what I find sometimes is that you have to repeat some of what had been said before by other persons. It's okay if it's redundant, but just the iteration, just the repetition sometimes at first some people might not grasp certain things. But if you keep repeating after a while, they'll get it. Of course, helping to manage chronic diseases such as the diabetes, the hypertensions, the high cholesterols, and so on. And addressing family level health barriers. What are some of those family level health barriers, class? When we talk about family level health barriers, what are some of them? What do you think are some of these barriers?
I'm thinking.
Anybody thought of anything? Have you ever thought of some of these barriers?
It said family level barriers.
Yes, Vanessa, family level, barriers at the family level.
Like cultural beliefs.
Ah, come again?
Cultural beliefs
Yes, Melissa.
or even religious beliefs.
Cultural beliefs and practices, yes. So cultural norms and traditions can sometimes conflict with public health recommendation, making it challenging for families to adopt healthier practices, yeah? Because remember that beliefs are not easily swayed, and people have a way of doing things within their household. We talk about the family subculture. And so, yeah, that's family level barriers. This is the way how our family do it. We drink the oil. Go ahead.
What about I'm not sure, but what about the hierarchy? What should I say no, like the head of the household, like if the father is not in agreement with the
So that's part
proposed,
of the culture. So you're talking about a patriarchal household
right,
where the
patriarch.
man, yes, where the man rules. The lion rules the roost. So whatever he says goes. And so it could be tantamount to abuse, don't you think?
For sure.
It could be tantamount to abuse when you look at it, depending on what the disagreement is. I would call it disagreement or contention is about. So the woman wants to do this, and the man says, "Hell no, you don't. I am the man in this household, and you're not going to do that. You're not going to take any contraceptive because we're going to have out our lot." Yes, I don't believe in that. I don't believe, some men barrier method condoms. No, not going to use that. Not here. Yeah. So of course, culture, the subculture within that household, I would want to place it under that, and some of that subculture really, as I said before, can border on being abusive. Lack of awareness. It says health education here, but lack of awareness. Family may not be aware of public health resources or the importance of preventive care and health education. So, the older folks in the family don't pay attention to health much, and maybe they might subscribe more to folk remedies and stuff like that. And so what you find is that, there's lack of awareness because, the children, the offspring within the household, they come up and they see parents doing and they just continue to do. Yeah, without questioning, because this is how we did it, and this is how we prepare our food, and so on. So part of the culture, lack of awareness. Economic constraint also is a family level barrier, Limited financial resources can prevent families from accessing healthcare services, nutritious food, and other essential healthcare. As a matter of fact, Oh, I don't know why my cursor is not working with me. Let me see this. So here are some of them. Here are some of the family level barriers. So you touched on cultural beliefs, and we touched on cultural beliefs and practices, lack of awareness, economic constraint, as I said before, limited financial resources, prevent families from accessing health care, the kinds of food that they need to eat, and other essential health-related needs. Transportation issue. The lack of reliable transportation can make it difficult for some families to attend medical appointments or even access health facilities depending on where they live. You do have families who might live in remote areas where the transportation system is not, you know, as good, for want of a better term, as persons living elsewhere. Remember that lady who asked the Prime Minister for a donkey? Even though, she lived, well, she wanted a donkey to transport the goods from her field. But you do have people who live in some remote areas in Jamaica where the donkey, the animal, the donkey or the mule is their main mode of transportation until they reach on the flat, we want to say, for them to get a taxi or something to go wherever. And so here it is, this kind of barrier would limit persons, would deter persons from seeking healthcare until maybe they're dying from preventive care. They're not going to just leave their community to go seek any healthcare. They're going to try other remedies before they come to you. Yes? Language barrier too. Families who do not speak the local language may struggle to understand health information and communicate effectively with healthcare providers. That's not a given here, eh? Everybody understands, like, for example, in Jamaica, we all understand the language.
No, not necessarily.
Who said that?
I have
Web.
Web might be,
Yes,
I have
Nicole.
had many instances where I'm sure I was speaking a different form of patois or English from the patient.
Ah,
But we do, though, have Haitians amongst us. And I've had at least one experience with an Asian who came post delivery. And
okay.
her English wasn't very good. So we were now at pains. Well, I was at pains to try to remember what I had learned many moons ago in order to communicate with her.
Right.
So we do have sometimes, and sometimes we have to ask for help. And then when we talk about language too, we have to think about those persons who are also deaf and sign language
I
is
was gonna come to
important.
that. And so there now is a real barrier where language signing is concerned. Many of us are challenged. We are the ones who are challenged where sign language is concerned, eh? And so because of our challenge, what we do now is handicap those persons because, people talk about handicap. Having a disability is not really an handicap in and of itself. But when the resources are not in place for them to just reach their full potential, that's where they're handicapped. So the fact that we do not, and I say some of you here might know how to sign. I don't know how to do sign language. And so that's an handicap right there. Because people who have this kind of challenge, who are, otherwise abled that way, can't communicate well with us. So I have to rely on writing, and some of them don't read very well. So therein lies a challenge. So you're right, Nicole. And remember, sometimes you're speaking basic patois. And I say all the time to undergrad students, you're speaking basic patois. And some persons do not understand because when you meet people for the first time, sometimes they have cognitive impairment that you can't look at them and tell. They're processing things slowly. And so you're there talking, and not recognizing that they don't understand a word. And you trying to speak basic patois. But as you say, you have different strains of patois. Some of the words that we use sound different in the patois, and so people might not understand. And some of them are afraid to ask, Doc, what you mean? But when you
Listen,
don't
the different
understand,
dialects is crazy. The other day I was watching something. I think that I'm assuming the person is from St. Elizabeth,
oh
and
Lord, please leave us alone, Vanessa.
I could not make out most of the thing. And I was like, this real in 2026? Like, how do I not know these words?
Leave us alone. Every time you guys talk about Pato, you talk about my country, you talk about my rural area. But it's true. We have a rich, thick, sweet patois, especially the south side of our parish. You know, just to listen to them, it's like a totally different language. And so sometimes I have to listen closely, and I'm from St. Elizabeth. I say to people, if I were to lapse in my kind of patois from St. Elizabeth, some of you wouldn't really understand what I'm saying. And I just love it. Yes. So of course we have language barriers, we have stigma and discrimination at the family level. So some families, you know, depending on you know, we have the classism and the hierarchy, you know, based on that class and so on. We mentioned that last time. And so you sometimes have families who fear stigma or discrimination, and so that prevent them from seeking health services, especially for mental health or certain infectious disease. You know, they prefer. They feel, for me, I think maybe it's out of embarrassment more than anything. Yes. Because I can't say for all my years when I switched from whatever it is I used to do out there in the corporate world and enter social work first before I did. All right, so just a little bit here. I before I did my PhD in public health, I worked. I had training in social work, so I switched from working in the banks to social work because I don't know, I just found out about this profession and just liked it, eh? But I've always worked in the medical faculty, even when I was at the hospital. You know, I worked on the psychiatry at the detox unit, and I don't recall, I don't see, stigma might be there, but the discrimination, for whatever reason, my observation, from my observation, persons try to, when it comes to discrimination, I don't see that. Let me put it that way. You who work in the field out there in you know, medical faculty, social disciplines, and so on. Do you see a lot of discrimination based on socioeconomic status? Talk to me.
I can't say I've seen it, but I guess that's also, it depends on where you work, I'd say, in part. Because, I mean, even in the past, working in rural areas, I mean, I guess I wouldn't have had perhaps someone who would have been in an era where they had the opportunity to be exposed to that kind of disparity. But when you're working in a deeply rural area, there's only one set of people you're seeing. So yeah, there is really no opportunity for that.
Listen, oh, Oshina is saying yes. Oshina, are you saying yes to the fact that you have seen discrimination?
Hi, yes, I have seen it. In the field where I worked, it was very prominent.
And what field do you work in, may I ask?
Aesthetics. So this is the beauty field plastic surgery,
Oh,
Botox fillers and stuff. It was very prominent in my field.
and people were discriminated based on what?
Okay, so I don't know if I should share, to be
And
honest.
we are mature people. You can share, but just be careful. If you don't have to divulge any sensitive information, but just be generic in how you respond.
Okay, so working where I worked, I come to realize that, you have like, middle class, high class, and then I came to realize there's a different class, which is the ultra rich class. So they have somebody from middle class that comes in and they want treatment. They're treated differently from other people who have a higher economic background.
Alicia said wallet biopsy. Hey, I've never heard that term before, Alicia. Whoa, wallet biopsy. Okay, but would you say though that the people who are mega rich, they get their
Mm-hmm.
service based on their ability to pay? So they can afford to pay for certain treatment, or is it that the persons who are, let's say, middle class, but can pull together some money to pay the same amount of money for the same service, regardless of the fact that both are paying the same, that the middle class person get less treatment? Is that what we're hearing?
Yes, because there would be comments on look on what she's wearing,
Oh,
that
Lord.
that her bag is real and stuff like that. Or oh my gosh, like not to bring up the skin color thing, like oh my gosh, she's so dark, why is she getting this?
In Jamaica here?
Yes, I did not know it existed until I started working at that place.
All right. Thank you so much. Thank you so much
You're
for that
welcome.
insight. Alicia, you have your hand up. Go ahead, please.
I feel so I've straddled both private and public practice.
Right.
The term wallet biopsy is, I guess, something that was coined to basically mean when a patient comes through the door, as Ashina was alluding to, some persons would assess what they're wearing, how they carry themselves, and determine whether or not they'll be able to
Afford.
afford the service. However, it also goes both ways. So I've seen where at some institutions, when the wallet biopsy is done, the persons who are deemed to be ultra rich are actually priced higher. So
Well,
they would
yeah.
say, okay, this person drives a Mercedes, they can afford it. So they're going to charge them 2 to 3 times the price because the prices are not published. So they actually charge them, the cost of 2 or 3
Right.
patients. And I've heard this happening to persons, including doctors doing it to other doctors, not knowing that the patient is a doctor. And then, when you go and you've heard of other practitioners where the patient comes in and they don't exactly fit their definition of wealth, the patient is treated a little hostile, like, okay, what do you want? Why are you here? So that's
Yeah.
in the private sector, but in the public sector as well, I've seen at some institutions where based on the skin color and appearance of the physician that and staff, that the lighter skin persons can talk down to patients and the patients say nothing about it. But if a dark skin doctor,
Yeah.
might be a little bit more firm or adamant about something, they write them up. How dare this dark skin doctor talk to me so?
Colorism. All
Yeah.
right.
So
So
it
yeah.
goes both ways.
Right. So that time, but I kind of smile because sometimes that wallet, what you call it, wallet biopsy can be so wrong. Yeah. Not everybody engages in conspicuous consumption. And so a lot of times they might look at somebody and
Pay less.
read them
So
wrong.
that means you'll pay less. So it works in your
Look
favor.
here, it works every time. It works every time. It works every time. It works every time. And sometimes you just smile. You heard me said before that I worked in the banking world in the 90s. I think I left with I worked with Eagle Merchant Bank, and I think it was one of the last places where FinSac took over. But I'll just say some of the wealthiest people don't dress very wealthy. working at that place, I realize that people, a lot of persons of means, are not the ones who are showy. I talk about conspicuous consumptions, not them. Yeah. So, yeah. What did
Miss,
I say?
but
Yeah.
you see it all the time with like some of not profiling, but a lot of the Chinese individuals who are very well off, you'll never know by what they drive. Because they're driving the same Noah van every time to the wholesale or to wherever. You're not gonna see what they really drive unless you're very, very close to them. And when they're going to the bank or other places, they're very simple looking individuals, very unassuming. So
Very.
that's definitely a point. But even in terms of I was gonna say, as a physician, I have even seen it on my end with my parents going to the doctor. I'm not that person that's gonna say, "Oh, I'm a physician and these are my
Yeah.
parents." They go in acting like regular people because that's what they are, and I'm
Yeah.
not going to say anything. And you may not know that I'm a physician, and I'm not going to tell you
Yeah.
because I'm going to see how you treat them. If I'm not there, I will ask them
Mhm.
how they,
Yeah.
appointment went or how they were treated. And on several occasions, you also have it be where the physician treated them poorly in terms of just the attitude. At one point, even with me being present, I was wondering, wow, okay, so nothing has really changed since med school. This person is
Mhm.
still the way they are over 10 years later, just talking down to
Yeah.
people. And it's not until, let's say, one of my parents would say something, then they would be like, oh, you're a physician.
Mm. Mm.
Yeah.
And
And the
attitude
whole
change.
tone of the conversation and how you're speaking to my relatives
Yeah.
automatically shifts and changes. And I'm like, it really shouldn't be that way, but it does happen. It
It does.
very much happens
Yeah.
all the time.
Yeah, those are the people that Shabba sing about, false pretenders. All right. Thank you so much for your contribution. Thank you. All right. So we looked at stigma and discrimination. It really is unfortunate, but it continued to be with us, apparently, the discrimination. Yeah. So childcare responsibilities, parents and guardians or guardians may have difficulty attending health appointments or engaging in health promotion or promoting activities due to childcare responsibilities. So they have to be home to take care of the kids or to send them off to school and to pick them up from school and all of that. So these are family level barriers right there. So lack of social support. So families without a strong support network may find it challenging to navigate health systems and access necessary resources. But addressing these barriers require targeted intervention and policies that consider the unique needs and circumstances of family. Again, I say our country having limited resources, financial resources, human resources, all of that. This is the ideal, but I'm not sure if we really can achieve such ideals anytime soon. Therefore, public health efforts should aim to improve accessibility, to raise awareness, and provide culturally sensitive support to overcome some of these challenges. You see, this last one here sound like you almost have to engage in a little bit of social work. Yes. When you look at it, because if you are going to raise awareness and provide culturally sensitive support for them to overcome some of these challenges mentioned, the challenges of stigma and discrimination, language barriers, transportation, economic. Usually I would say, and I keep referring to undergrad students that I teach, this is where the interdisciplinary approach is very important. You can't do all of these things by yourself. Time as a resource alone, you don't have to do this. And so you have to network with people who, this is their responsibility almost to do these things, to link persons to resources, childcare responsibilities and challenges there. The social worker helps in that regard. Economic constraint, transportation issues, sit with person, talk to them. I tell you, the social work I find is such a resource that's underused in our country and under-recognized, I would want to say, in our country, based on the kind of work that they're doing quietly there. They train the social workers because you have social workers and you have social workers, I find. Right? So here we've just looked at some family level barriers. Every time I click my cursor, right? So here we go. So now we're going to look at family-centered healthcare. What time is it? All right. So we have quite a bit to put through here. Universal health coverage, it says here. So key components of family-centered healthcare includes health coverage that entails all members of the family and an insurance system which is portable and independent of pre-existing conditions. Simple forms when people want to claim or to be reimbursed and using these easily understood forms and working with numbers and charts that the family can easily understand and claim. A lot of regular families, we talk about free healthcare. We know it's not really free. Yeah, it's just a semblance of. So really I speak of Jamaica, to which I'm most familiar, universal health coverage. I don't know if we are going to get there anytime soon, but we can just hope. A lot of the things we hope. All right. Moving right along now to look at practical access. This one says secure the family-centered healthcare system. Practical access to service. One consideration is affording family access to not just a comprehensive continuum of services, beginning with preventive and primary care, outpatient mental health services, and family therapy. And if you notice, I have the community health aid here. I think that the community health aid are important part of the health network if they do their work. I'm saying if they do their work, right? So support may be also considered for persons who are caring for members with disability or who have severe chronic condition. This support I'm talking about could entail educational and community-based home support, of which the community health aides would be very integral. Many public health centers in Jamaica have in their employ these CHAs who can be instrumental in providing some of those support in terms of outreach services in homes and neighborhoods. Can you think, class, of any other category of staff that could be utilized for outreach? So we have the CHAs. Anybody else come to mind?
The HEOs, the health education
The
officers.
health education officers, yes. The psychiatric aides, they're out there too with the nurses.
That's true. And even vector control too. The vector control workers, they're out in the field.
They're out in the field. Yes. So more outreach services in home. So practical access to service here, subsidized transportation costs, flexible scheduling and accommodation for, persons, the families that have special needs. We're yet to get there where these things are concerned. So I'm saying the politician among us, those persons who want to go in politics to make, more impactful change, change that's far-reaching. Think on these things. So professional staffing. Training all healthcare providers, it says here, in the biopsychosocial model of care. Sorry about that. Why is the biopsychosocial model of care so important? And
Because
while
it
you,
really,
yes,
go
go
ahead,
ahead.
Doc, go ahead.
No, you go ahead.
Now, I was gonna say because it not only it acknowledges and emphasizes that health, from the definition of health itself, it's not just about the biological aspects. There are so many other equally, if not in some cases, more important aspects that contributes to health and wellness.
Right. So you can't divorce one from the other. As I like to say, one will be more dominant at any given time. But a lot of times, the biological, the medical problem with which an individual presents could be spawned by psychological issues. That person has a mental health concern or a mental health problem and not taking care of self, or because of this mental health issue, the person, does something that's detrimental to the person's health. And so this now contributes to whatever the medical problem is. And because also the person might have a psychological problem, a mental health issue, and the society, the people with whom this person has to interact, there was a time when people used to just physically abuse persons with mental illness, right? So what would be dominant at that time? I think the social issue might be dominant, persons not being very educated about mental health and people with mental illness. So they abuse them. And so they come to you with medical issues. And so all of these are tied up. But what's important for me also, where the biopsychosocial is concerned, is that when you are able to use this multidimensional approach or model to do your assessment, it also helps you to understand how to intervene. So you use the biopsychosocial model, looking at the three components, and depending on which you think is the area of focus that needs to be targeted more, then it helps here with your intervention. And I find it to be very important like that. So training all healthcare providers and allied healthcare professionals in the biopsychosocial model of healthcare is important. Teaching them how to assess the influence of family factors on health and to work in partnership with family members to provide the health, to promote health of all family members. Now, managed care and cost containment. In terms of managed care and cost containment, we're looking at, assessing the family circumstances and their effects on family health functioning. Taking into consideration the family members may react to the burden and stress of caring for family members and therefore becoming ill themselves. Yeah. So assess patients' life context, the family values, the resources that they have, the needs, and how all of this affect families' functioning, the level of support and well-being. So managed care. Yeah. Family circumstances and how this affect. Because a lot of times the caregivers, they are burnt out. So they become sick themselves, as we say. Not only that, the person who is being cared for sometimes feel guilty and feel useless. Yeah. How can they contain cost? Because the severity of the illness or the condition of the person being cared for, if it's prolonged, if it's chronic, if it, it goes on for a protracted length of time, of course it's expensive. Medical care is expensive. So how can the family contain cost? You might say, as public health practitioners or medical doctors or whomever, is this really my is it onus on me to do these things? Maybe not. But here, because you work so closely and intimately, I want to call it, with the people in your care, you can have an idea that these things are happening. Yes, burn out is taking place, and the financial burden on the family is real. And so you refer. That's why I like to talk about the interdisciplinary approach to the work that you do. So you refer to persons.
But there are also simple things that we can do in terms of, for instance, if you know that a patient goes to mental health clinic, but they also have diabetes, something as simple as collaborating with
Yes,
the
yes.
mental health team so that the patient's two appointments coincide.
True,
And
Nicole.
the patient don't end up coming to the clinic multiple times when they could have come for one visit and they see both teams.
Yes,
So
that is
things,
so true.
things like that.
Yes.
Even for somebody who may need family planning, it's just about collaborating, recognizing that the patient may need multiple services and trying to coordinate the services so that the patient only
Pays one bus fare.
pays one bus fare.
Yes.
And sometimes it's identifying gaps, like even on an NHF card to say something might not be covered. Just little things like that, remembering that, okay, I'm adding a new medication, so this patient will need her NHF updated. So at
Right.
least when she goes to purchase it, she can get it.
At a more subsidized cost. Thank
Right.
you so much. I wasn't even thinking along that line, Nicole, but that's so true. Thank you so much for that input. All right.
Sometimes the issues are embedded in the system. For example, with the new what you call it, data system that we're piloting in places like the health center, like Greater Portmore Health Center, Spanish Town Hospital, Mandeville, and so on. Sometimes the issue is there, which it doesn't allow you, because I encountered that from psyche to curative. But then sometimes it's also personnel wise, because when you try to, okay, it's not within the system, but then we can circumvent the system and deal with it. Persons are not willing to just, make that accommodation. It's not in the system. And so,
To extend themselves like that.
yes, and to look at the situation on the patient and to say, okay, yeah, because if this blood pressure does not get under control, no matter what we're doing over here, it's not going to be of any good consequence, because she's going to have an issue. And so, you need that change. And even when sometimes drug interactions, and patients feel better on one type of medication as opposed to the other, sometimes we're not flexible enough.
Yeah. So the care is not patient-centered enough. Is it Hamilton?
Enough. Yes.
Yes, Johnson Hamilton, yes. Yeah.
And like Nicole is saying, you really have to, advocate strongly that patient, that they does not just fall through the cracks, but does get the assistance that is needed.
But you see, when people do not work, that kind of team approach, I just listening to you, Nicole, just listening to you, Johnson. I'm thinking to myself, it must be so tiring, just psychologically tiring because advocacy is not easy. If you have to go lobby and to have to agitate to say, but this could and that could, when you just feel like somebody say, oh yeah, I think that is so true. Let's do it this way. Excuse me, I would think that in facilities where people have regular what they call it, conferences, like case conferencing and so on, and meetings like that something like this could be discussed, and everybody might not come to a consensus, but at least by the democratic process, hopefully the majority would carry to say, yes, these are some of the things we could do. Even if the system doesn't allow, we could do this manually, and we agree to this and so on, just to make life easier for you. So this is something that you could probably consider. Yeah. All right. Thank you so much for your input there. So We're changing gears now to really look at some principles of family health. And the first one I have here is family support. So the following now, these principles I'm talking about are some broad principles recommended, which are recommended by the Consortium of Family Organization to guide the development of family-centered and family-friendly healthcare system. Now, this Consortium of Family Organization believe that healthcare financing and delivery organizations should support and strengthen the roles of family in the promotion of healthy lifestyle, disease prevention, and the treatment of members in ways such as giving incentives to encourage healthcare providers to consider family as a focus for support and services. So family support, strengthen the roles of family in the promotion of healthy lifestyle, disease prevention, and treatment. Come cursor, work with me. All right. So we have here now family partnership and employment, treating families with respect as a key consultants and partners. So this is now alluding to that family-centered care of which I mentioned. We talk about patient-centered care. Now we're talking about family-centered care. Empowering families to carry out health-related responsibilities. How do we facilitate this process of empowerment of families to carry out health-related responsibilities? How do we do that? How would you empower families to carry out health-related responsibilities, class?
Can you repeat the question, please?
So I'm asking, it is saying here, family partnership and employment, that family-centered approach. And the second point mentions empowering families to carry out health-related responsibilities. And the question I asked was, how do you facilitate this process of empowerment where you help family for them to carry out these responsibilities?
Well, I think part of it is that some family members are not educated on, say, like the conditions that their children or whoever is there in the house suffers from. So I think education, probably teaching, getting them involved in helping with giving the medications. Probably, well, you had used an example of language being the barrier. So a lot of people don't realize that sign language is there. So that could be another thing as well.
Is it Elisa? Elisa Leila?
Melissa Lala.
Oh, Lala. I see the E, I didn't see the M. All right, so it's Lala. Melissa, yes. Yes. So health-related responsibilities, clear, unbiased information on how to access resources, how to support and carry out the responsibilities that they have. That health education is important. All right. Alicia, you have your hand up. Go ahead, please.
Right. So I interpreted this sort of along the lines where businesses and employers can actually assist family members with their responsibilities by giving things like time off to go to visit the doctor with a relative, and offering them some sort of health insurance or health beneficial programs at work for their families as well. So like daycare and so on to assist with
Yes.
responsibility.
So that's the what's the word I'm looking for? That employer who is sensitive to the needs of his or her employees. Because some persons really not empathetic and they're not sensitive to those needs. They just don't care. It's about the money and people working. Yes. So that way, yes, go ahead.
Right, I was just saying, just to add to what Melissa said, in addition to this business of incentives, it's working through access arrangements. So, like with the parenting suite at the Bustamante Children's Hospital, having facilities where when people have sick people, they're allowed in the space. There are some provisions for them to be physically present with their folks. I think
Right.
is something else that the health system needs to look at, or that is one way to enable family.
Yes. Thank you so much for reminding us of that, sweet. And so providers need to be open-minded about the family's need to be involved in the care and support. So that family suite right there is affording them that. Yes. Because people want to be involved in the care and treatment and support, of course. Be supportive also of who wants to be involved with the care
Just
of
to,
their
to,
loved
to add
one.
another point as well,
Yeah.
many times we think about the families and we think of parents and children, but
Mm.
also you have some children who have to take care of elderly parents, and some workplaces do not give consideration towards that.
Exactly.
I,
Yes.
I'll be very frank. I remember one situation where my mom was ill, and I requested the day to follow her to get a procedure done. And having told my consultant at the time, I was rebuffed the next day I went to work, where I was told, not by my immediate consultant, but another consultant, that the only time I should miss work for a parent is when they're dead.
What?
This is a physician. Yes, yes. And I was so flabbergasted. I didn't have a response to that.
I would cry.
But I was told the only time I should miss work for my parents is if they're dead.
Wow. Mm.
In my experience, as horrible as it sounds, like it's very true, and in my experience, as opposed to crying, um, I'm a bit of a vocal person when it comes to certain things. So I ended up in a meeting for apparently
Being
being
insubordinate.
being not just insubordinate, but on that specific insubordinate is one specific one that came up on a different occasion, on a similar occasion, for being apparently unprofessional in my response, which I must say in retrospect I was, and very deliberately so. But it just emphasizes the fact that there is very little consideration for the human aspect of things in some senses, and it's
Right.
almost like you're a robot and you have to make a decision for yourself in certain moments what you're going to allow yourself to deal with and what you're going to let people get away with. And once they feel like they can get away with it, they're going to keep trying it. And once they still realize they can't get away with it, then they're either going to do two things, and it's going to be either to get you out or and try to make you the bad guy and punish you, or they're going to comply and work around you.
It is, I think it's Dr. Phil who says you teach people how to treat you, yeah? Yeah. I can be very vocal too, Akeem, very, very vocal. But just to say that, Alicia, I'm flabbergasted myself just listening to you say that. Because I know I would cry, but when you see tears come, when I get angry until tears come, well, my mouth don't have any shutter, so I will just talk. But before you, I just reading what Johnson Hamilton has here, having the family be part of the planning for their care. And when they do this, they gain ownership and become invested. And that's such a truism right there. Yes. Daniel is saying unrepentant, they're horrible. But you would have thought that, your colleagues, Marky, some people might have seniority, I think they call it, but you're all colleagues, and to treat colleagues like that, the most I can say, boy, I really can't identify with that kind of treatment, honestly. I remember though when my mom passed, and I went to my head of department, and it's not like she was saying I couldn't go or anything. And I said, this has happened now. Like I was on my way to work, they called me and they said, this is what had happened. And I went to her and said, okay, I'm going. And she's saying something about leave. And I was just kind of peeved that she asked me about leave. So I just told her that whether or not there is leave, I'm going. It doesn't even matter whether there is leave. I say I have leave, but whether or not I didn't, I'm still going. At that time, grief and everything overtaking me, asking me about leave. But As I said before, it's not that she wouldn't have allowed me, but maybe she was just making certain I have time off because, you know, but
Miss, as you said that about leave, there's a physician, a consultant who I remember had gotten held up at gunpoint on a clinic compound. And
yeah.
when she had called to actually report it, that was one of the first things that was said to her. Okay, just make sure you bring in the leave paper. Not caring for the fact that this person is probably extremely shaken up. But it's just okay, bring in the leave paper as soon as you get a chance. So there are lots of it might be a shock to you, but I think especially for those of us that work in the medical profession, there are lots of very I wouldn't say heartless, but they're just the humanity aspect, as Akeem said, is just lacking a lot. So it happens more than you think.
And I want to just add, not to belabor it, it also matters to where you work, because I think this has in part come up before. And like I said, I worked in so many places. I really have seen a significant variation in how you're treated based on who you're working with. Because working on certain firms, at certain institutions, I've seen some and experienced some very interesting things that had me going as far up as to the region with my issues, because I'm not the person you're going to walk over. And if you think you know people, I know people too. And two, in another sense, I've worked in a setting where I remember working on anesthesia at KPH. I have never since then worked in another setting where I felt as welcome, as heard, as taught, as it was just a very, not so much friendly, but it was the kind of energy and environment that made you want to do well, you want to work, and you never felt oppressed, or you never felt as if you had to, you were being spoken down to or anything like that. So it really matters who you're working with.
And I hope from all these experiences that you all purpose in your minds that this is not something that you're going to propagate, something in terms of the horrible behavior that's been meted out and meted out to you, but that you're going to change that kind of behavior. So, when people are around you, you're going to be nurturing in a sense, as you say, maybe not friends, but friendly enough and caring enough about other people. Because that is what it's all about, eh? How can you, if you cannot care for your colleague, if you have no empathy for your colleague, I mean, I'm sorry for the patients. Wow. So as you said, Akeem, it's really is a food chain. And so, it's like a dog eat dog out there. Wow. I'm learning so much from you tonight, because I wouldn't have thought that, these things happen within your fraternity, I want to call it. But continuing here, I want to say that families should be allowed a maximum degree of choice and decision making within legal limits. Yes? Because to provide effective health services, family diversity must be appreciated and respected also. So this is my moving now to this other slide, continuing with family health principles. And so family diversity is very important here. Diversity in terms of structure, resources, culture, religious backgrounds, and family setting. And so that setting, urban or rural. And when Akeem was speaking, I wondered to myself, because working in a rural setting and an urban setting, I wondered to myself, Akeem, which was more nurturing for you, the urban or the rural? And the reason I mull over this was because I find, born and bred in a rural area, when I came to Kingston, the culture in the urban city was almost like a culture shock for me. The kind of family environment, my district, everybody knows everybody looks out for everybody. Just the little things that people used to do back then. Just the sharing and the caring. when I came to Kingston, and that just wasn't there. Class, just the very idea that I could not go through the gate and just walk to somebody else's yard because, your family is there. There was no fence around the houses. Now, when you go back home, people have their walls and their fences up. But then there was no fence. You just walk. You just go pick fruits everywhere and stuff. Yeah. And so the culture in the rural area was so much different. But nevertheless, that is an aside. All these variables now, structure, resources, culture, religious background, family setting, and family involvement, shape the family's need for health services. They also shape their responses to illness and how families utilize health. So we're talking about the family structure, the constellation of the family. Yes, single-headed, blended, single parent. Well, I said single-headed already. Extended family member. What's the structure of that family like? What resources are available to the family? Yeah, the subculture of that family. We touched on some of these things before. Emotional damage, right? They're really just background. We spoke about belief. And it's important, yes, some persons might subscribe to a particular religion, but it's important to find out if they're actively engaging in the rites and rituals of that religion. Why do I say this? Sometimes, let's take, for example, somebody who might have been born and bred in a household who, people are Jehovah's Witnesses, and this person's child needs blood. So you take it for granted because the person said he or she is Jehovah's Witness that they won't take blood. But maybe this person said, yes, I'm born and grown in a Jehovah's Witness family, but here what, give my child blood. You never know. So you need to find out, don't just assume on these things, but just ask the questions for you to make a decision. Yeah. So the family setting also is very important. So apart from the structure, where is the family? I would want to say the setting expanded to look at the location of where the family is. Yes, the socioeconomic background. So some of these things we've touched on already, but just the diversity where family is concerned. You have some family members who are integrally involved with what's going on with other family members, and some are totally detached. So all of these things you have to gauge while doing your assessment. And how are you going to find out unless you ask? You have to ask the questions to find out and understand that as a principal, you have to consider the diversities within families or among families as you work with them as family health practitioners. And I'm changing gears now to look at thinking family. According to Crandall and some people, 2019, in thinking family, they look at some principles, yes? And these principles are used in applying the family impact lens in policy, programs, and practice. The guiding principle provides a framework through which practitioners can carefully consider the impact of policy and practice on the whole family context. And so they have family engagement right there. Public health practitioners who think family ensures that families are actively involved in all the programming phases. You see, this sounds redundant because when we looked at, earlier on, we mentioned engagement of family as one of those principles. Yes. You also want to look at family responsibilities, how stable the family is. And again, we say diversity in terms of structure, culture, religious beliefs, and all of that. Yes. So you have to think family when you are working with in family health, put it that way. All right. I'm not even sure if we need to belabor these points because These are almost self-explanatory. As I say, as you go through, you recognize that some things are redundant based on what we would have discussed already. Family stability. When we're talking about family stability, you could also look at this in not just economically, how stable they are financially, but you could also look at how stable they are where interpersonal relationship is concerned. Because families sometimes become fractured for whatever reason, and that family really isn't stable. Also, anything could have happened to cause some kind of disequilibrium within the family. It could have been act of nature, like Melissa, yeah, or an earthquake or mudslide, inclemency, and you have mudslide or flooding. Illnesses also can cause instability within families. And so here, when you're thinking family, when you're working with family and looking at the family's health, you have to look at how stable, you have to look at how an illness would impact that family. And so roles might have been changed. So roles discontinuity in one sense, role change in another sense, role confusion sometimes, because people not quite sure, where I stand here. Boy, I'm the child. I know I'm taking care of my parents. What am I? Yes. So family, and that can cause instability within family. And tied up in all of what I've just said would have been family responsibility too. Who is responsible for what? Yes. And if that person who has the major responsibility, something happens to that person, what? Yeah. So those things that you do on a daily basis are re-emphasized here when you think family. So applying family health principles now. The family is seen as an actor within the public of public health, according to these people right here. So you see how essential the family is within public health, right? So that just looked good and I have it right there. But in applying family health, it requires a number of things: an appreciation for family-centered healthcare. As we said before, engaging family members as partners, accepting and respecting family diversity. So higher order skills, I consider when you're applying family health at this level to be higher order skills of applying family health principles require this kind of appreciation. Yes. And so, as I said before, believing the family is an essential actor within public health. And so when approached as a partner now, families may facilitate better overall health outcomes, or this can facilitate better overall health outcomes for individuals and whole communities. So even though family members may not be medical experts, they can be experts at monitoring and conveying information in relation to rehabilitative and remedial care of family members. This is, and so this partnership should be cultivated, should be fostered. Yeah. All right. So I think this slide, yes, family members, partners, and accepting and respecting their diversity. Now, we're going to look again, or continue rather, looking at some perspective here now on applying family health principles. And the first perspective here considers the larger context of the total family when planning and implementing health promotion programming. So you see here that, a lot of what I'm saying here, we would have discussed in a different way already. But these perspectives are also rooted in family impact principles of family engagement, family diversity, family stability, family responsibility that are designed to facilitate thoughts of how proposed and existing family policies and programs support or hinder families. So with regard to this perspective here now, and I'm talking about, excuse me, this perspective one, recent demographic shift, like, the growing proportion of of older adults, an increasing number of multi-generational families, and more people living alone will necessitate a critical shift from the traditional public health focus on mothers and children to a larger context of the family. So you're more like taking a panoramic view of the family's ability to nurture. So the family's capacity to nurture, to care, to protect, looking at this in a larger context when you are planning health promotion or programming. Yes? So perspective 1 here. Moving along to look at perspective 2. And I'm doing this quickly because, yeah, the time is running out on us. So it says, frame the importance of family health for policy and funding decisions, because here, the educational levels of individuals are usually tied to the kinds of employment an individual has. So attention to higher level education and employable skills attainment can help to stabilize and strengthen families. Hopefully, if the household is financially stable, family members can stay together and be able to afford health-related resources. Yes? So just in a nutshell, looking at this perspective here, expanding health benefits to better provide economic relief or access to health services. Somebody mentioned family leave policies for major life events such as childbirth or caring for chronic family health needs is also very important. And it's, of course, from our discussions, we realize that we have employers who are not so caring and sensitive to some of these needs. So sometimes you have to take the bull by the horn like Akeem does, eh? But always think, though, your actions, you always have to think it through. Don't be impulsive. Think it through. Sometimes we can just
I was about to say that don't be like me. You have to think, be thoughtful before you make certain decisions, and make sure you have an out plan.
Yes,
Because
that's
if
what
I
I'm
didn't have
that's
my
what I'm
out plan
saying.
into
Yeah.
private practice, I might have been in a very tough situation. Hence, I'm in private
Exactly.
practice now, but don't do
Right.
like me.
So you see what I'm saying? I'm saying think about it first before you, don't be impulsive. Sometimes, in the country we used to say you stay on crooked and cut straight. Yeah, that's one of the Jamaican proverbs right there. All right. Family health policies, we touch on that, revisiting in incarceration policies that foster family ties or favor a quicker reintegration of, with family members. And this one, I would want to add that, as it revisited these policies of incarceration, that I think if what I want to call soft crimes, some of those crimes, not the hardened kind of criminals, I don't know, a quicker reintegration into family, no. Sometimes some of them are abusers within the families and they need to stay where they are. For example, and it might not be proper for me to say, but I'm going to say it anyways, that young man who massacred 5 members of his family, no. If he has a family, let's say he had a consort and had kids and so on, a quicker reintegration into family, I don't know about that. Yes, so revisiting of these incarceration policies to foster family ties, I think, is dependent on the severity of the crime that was committed. So we turn to perspective 3. And it says, partner with families to demonstrate optimism, belief in their capacity to improve health outcomes. So families, as I said, may be unaware of some public health systems and how it can help them reach their health and well-being goals. Once aware, though, families may also distrust public health services due to limited experiences or other factors that they might have learned, whether from lived experience, I want to say, or vicariously. So gaining the confidence of a parent or any member of a family means the practitioner must avoid certain things. Yes. So avoid disparaging views of the family capacity. and resist a conditional basis for wanting to partner with the families. Resist a know it all or we know better approach. Even if you know better, don't say it. Yes, and be careful how you act it out, because you might not say it straight to their faces, but you might act it out crookedly. So you have to be careful of those nonverbals and acknowledge the rights and privacy of families and their need for independence in carrying out some of the responsibilities that they have. All right, so we're moving right along now to look at perspective 4, the focus on strengthening family mentors in the community. So the public health is a product of individual and family choices, which in turn influence the health of the community. So the application, when we talk about, family competence, autonomy, we really are talking about self-determination. And so the application here of the self-determination theory in public health entails nurturing the individuals and the family's capacity to make healthy choices while allowing them to retain control over their lives. So the concept here of mentor mothers trained to conduct home visits and assist families through the barriers that these families faced. Many have said, or the research has shown, that they have contributed to positive child health outcomes, improved because the highly trusted mentor bolstered the caregiver skills and capacities. And in Jamaica, I think that's, I won't say synonymous with, but in Jamaica, we have the not early childhood education. But I'm trying to remember the name now. It's eluding me, but it's in the health centers where you have the well baby clinics. It falls under help me here, medical people. So you have the well babies. You have those videos that are shown in some health centers, the videos and so on, and new mothers being trained how to, deal with their babies. If their babies kind of become a little bit antsy, how it is they treat the child. And then you have these the community health aides from the maternal child health section who will go in the communities. And so these CHAs, I consider them to be akin to these what they call them, mentor mothers. So they'll go in the communities. Some of the CHAs who work with maternal child health. If a mother didn't come to clinic, they miss like their 6th week or something, and a child is due vaccination and so on, and that they're not seeing that child, they go in the community looking for those mothers. These are the persons I consider mentor mothers, trained to help these young mothers, for example, kind of work through some of the barriers that they might be facing as young mothers. And so this must improve. I can understand how this will improve caregiving skills and capacities of these young mothers, for example. All right. Perspective 4. What did I just do? Click. So perspective 4 here, the focus on strengthening. Oh, didn't I this is just what I read, right? So it's perspective 5 that I'm at now. Strengthen family capacities to model memorable and positive health practices through their development. Children and young adults who witness many types of household, and from their observation, they draw conclusions from which they might generalize their own potential future families. So the long-term public health impact here is for this perspective is important, particularly for their impact over the life course. So this is where the modeling comes in, where when good health behaviors are modeled within family, hopefully this is propagated by the younger generation, children and young adults who are coming up and who make these choices, these future choices. Perspective 6, health promotion, empower families to assess needs, capacities, and design solutions to their own problem. Remember, the problem belongs to the families, but our facilitators, you are persons who are going to help them, yes, to identify those barriers and how they can surmount some of these barriers. But all in all, you're not going to take on their problems. For me, the epitome of empowerment is when individuals and families are able to identify what their needs are, identify, their strengths or weaknesses in this regard, their capacities. And so they can come up with innovative ways even to help to resolve their own issues. So as health promotion practitioners, though, you can regularly assess members and involve them to solve their own problems using models in public health, community-based participatory research, for example. Yeah. So a comment here, let me see. Right. Thank you, Johnson Hamilton. All right. So community engagement. These relationships work together through a process that is founded in empowerment, health promotion, health equity, gender equality, human rights, and planetary health, if you want to look at it this way. So community engagement, this process of developing and maintaining relationships that enable people to work together to address whatever issue. And so the process of working together, you're reading this yourself, is navigated through dimensions of compatible values, interaction that are based on respect, dignity, and compassion. That compassion, you could use this interchangeably with empathy, active and inclusive participation, conjoint decision-making, equitable. Sometimes it might not be, fairness, as we said, doesn't have to be equal, but equitable. And the equitable dynamic flow of power, control, and resources. Somebody mentioned flexibility earlier on. And when we are looking at this community engagement, we are again using the systems level. Yeah, this ecological model spanning the micro way up to the macro level of human interaction. Right? I'm speeding up because I think our class has been so interactive that we are running a little bit behind time. So this diagram, we are looking at the integrated change framework here. Yes, it's still community engagement, but here's a integrated change. And this diagram proposes strengthening relationality or relationship in the community engagement for the health system. So when we look at, so it starts at the bottom. It starts at the bottom with leadership right here. And so leadership here, the health system now recognizes the important role of leaders and managers in taking a whole system approach to building responsive, resilient healthcare system. So championing and rewarding relationship and building collaboration. And so you move up now to system-wide ecosystem. So this really is looking at things, as we said before, the micro-meso ecological system model. And so the system-wide ecosystem now focuses, or this integrated change framework focuses on network of teams being the core of health system, spanning structures, functions, and activities. And these teams act as communities of place and purpose. Remember the last time we spoke, we talked about community, geographical communities and communities of interest. And so this here now, where collaboration and integration take place, spans both communities of place and non-place. So place or purpose, using professional and informal relationship to meet the shared health priorities. And so at the organizational level, daily conversation form invisible structuring and feedback loop that influences system ability to self-organize and learn. And what system we're talking about here? Remember, I said to you, an individual could be a system. The families themselves are systems, right? So always bear that in mind. When we look at the participatory facilitation and convening skills, what are we talking about here? Now, the World Health Organization conceptual framing of relational community engagement emphasizes the science of communication, yes? And they consider this to be bioactive. And so its role in fostering healthy social connection and interaction lodge in intentional group convening. So yes, it's okay for you to have the one-on-one, but convening meetings. Sometimes it could be workshop. Do you all have the time to do that? Workshops, those health talks. Sometimes you as the doctor might not be able to be doing the health talks, but I've seen, and when I talk about early childhood, oh gosh. But anyways, you have the CHAs themselves who are doing these talks, the maternal child health nurse who is doing the talks, and so when you have this kind of facilitation, when you have this kind of interaction, it's intentional and iron sharpens iron. So the people there, sometimes you're relaying the information and somebody in the group is better able to convey this to the other group members for them to understand in a better way. So little things like, so this participatory facilitation is very, very important here. And of course, research, mixed methodology, qualitative, quantitative methods. Yes. And so the integrated change framework underscores the importance of social and contextual data, requiring integration of basic social science methods. Yes. Key informant interviews. And when you talk about key informant interviews, we're talking qualitative here, right? Focus groups, into health service programming, and employing mixed methods require minimal specialized skills and provide valuable insights for decision-making, service design, delivery, and advocacy. Yeah. So when you do the quantitative is asking, how, and then the qualitative is telling you why something happens. And for me, that is why I kind of like the mixed methodology approach. Because you see a phenomenon, you ask the questions, you probe, and then you get a sense as to why you're seeing this happening, even among a subset of the population, a sample of the population, and so on. All right. So data integration right there. And you see here potential of teams, connection, belonging. So read this, you can go through this at your own leisure, right? And so I've added some narratives here to make things a little bit easier. Leaders and managers taking a whole system approach to building responsive and resilient healthcare systems. So as you will get, I'm almost sure, well, kind of sure that this slide should be available, but I'll send it to you. I have my notes. And so I say to students, pay attention to the notes that I have. When you get my PowerPoint, pay attention to the notes. What is this I have here? The problem tree. When we talk about, the community participatory method, I just put this here as a problem tree to say, when you're in communities, you identify a phenomenon that you need to understand the root cause of this problem and so on. You go to the people. And you can use this as an example for people to be involved, community members to be involved. You ask them about the root cause. What is it, that's causing this thing to continue, and what are some of the results, the impact, the outcome of whatever is happening? And of course, in using this diagram also, it's a problem tree, yes, but you can help the people who are helping you to identify some of those root causes, the propagating factors, and the impact of the problem can also help you to identify solutions, because people know what they want. They have the solutions within themselves. Sometimes they just need somebody to elicit that kind of information from them in a structured way. All right. I want you to go home I want you to, I too been at work. Some challenges and strategies I have here. Limited resources. We know that cultural barriers, we've touched on that already. Overburdened community services, and of course, things that can be done. Community outreach. One of our colleagues here mentioned advocacy and employing technology in some instances, reminders, the phone can, as it relates to sometimes you're teaching persons about medication. Some people say they forgot to take the medication or forget to take the medication because so on and so. And they have their smartphones, this thing can be plugged into their phone and as reminders, the alarm goes off to remind them to take medication, stuff like that. All right. Yes, so we are winding down. So in closing, we can't do it alone. There is strength in numbers. So Crandall and others, 2019, believe practitioners engage in developing and reviewing population health programs can assist public health to think family, support families in performing responsibilities such as relationship, child raising, and caregiving functions. So you see how population health and public health, the two are kind of in alignment, I want to call it. Now, according to Lay University College of Health, public health leverages population health insight to develop policies aimed at advancing community health. Or, in other words, public health builds on population science insight, and together they are catalyzing better health outcomes around the world. So, of course, in population health draws on economics, epidemiology, engineering, environmental sciences, so on and so forth. Public health focus on, and of course, epidemiology, some of these very things. Yeah. And so public health focuses on community-wide concerns rather than the health interests of particular individuals. And they pursue programs and policies that promote community-wide health. And these are distributed among populations, share socioeconomic and so on. So you see how aligned population health is with public health here. So yes, practitioners of population health program working together with public health practitioners to think family, I think is a good combination right there. So that's why I developed this slide. Impact principle. Family engagement, family responsibility, family stability, and family diversity. And the qualifications are over to your right. Again, I say, you can read at your own leisure. These are self-explanatory. All right. So inherent in our discussions earlier on, I'm wrapping up now. We've looked at family health principles embedded in a holistic approach, prevention-oriented principles, equity, access, community, integration, and cultural sensitivity. So for those of us who were paying attention, we realized these are some themes that were inherent in our discussion tonight. In thinking family, it's important to learn skills where practitioners reflect on the connection between individuals and families. And for public health, thinking family ensures that programming strengthens, not weakens, the role of parents and other family caregivers. And this is what Crandall said. All right. Yes, so this brings me to the close of my session for tonight. And I leave you with the words of Gandhi. The best way to find yourself is to lose yourself in the service of others. And as public health practitioner, whether you believe it or not, I think, to some extent you're doing just this. Thank you so much for your participation. I meet with you again tomorrow night when we have special needs panel. Yeah, tricky one. Some persons are calling late to say this and that, but we're gonna get through our session. All right. Have a great night, everybody. God bless you.
Take care, dog. Take care, everybody.
Thank you so
Good night.
much.
Thank you.
You're most welcomed.
Thank you. Good night.
Thank you, Alicia. Have a great one.